Well, I hate to interrupt all this conversation, but we're going to have a lot more around dinner. But first, we have a very special guest, and we're really excited to welcome Dr. Meena Seshamani, who many of you know is leading efforts at the Center for Medicare focused on innovation. She's Deputy Administrator and Director of the Center for Medicare at the Centers for Medicare and Medicaid Services. And Dr. Seshamani is not only a medical doctor, she also has a PhD. She really is accomplished in many domains. She's a strategic leader with deep understanding of health economics and really a long-standing and heartfelt commitment to outstanding patient care. At CMS, she's responsible for policy and operations for the healthcare coverage of more than 64 million Americans in the Medicare program, with an annual budget of roughly $1 trillion. She's Hopkins-trained surgeon, Oxford-trained PhD economist, and she was a Marshall Scholar. Please join me in welcoming Dr. Seshamani. Well, I know so many of us were excited that HHS came out with an issue brief titled, HHS is Taking Action to Strengthen Primary Care. And it was in the frame of the National Academy of Science, Engineering, and Medicine recommendations. Yeah. And we're excited, and we want to partner with you all to do more, because we know the need for addressing health equity and really restoring the health of the American public is so urgent. So my question to you is, how can primary care meet the very well articulated goals of the administration to advance health equity, to improve our population's both physical and mental health, and make care more affordable?
Well, it's great to be here with all of you. Thank you for having me. And I think you all know the answer to the question of, what role, primary care can play. And it's something that we absolutely see, to the point you made. We released a report across the department around the importance of primary care and steps that we're taking. And I think it's very important that this was done across the department. And in fact, it's analogous to the role in some ways that primary care plays in the healthcare system, where you have to view health as something more holistic than just an individual disease, right? People are more than the sum of their diseases in terms of caring for them. And I think that is central to primary care. And I think that ultimately is what fuels the power that primary care is to really drive improvements in health, because you are able to think more holistically about a person and everything that impacts their health, mental, physical, the socioeconomic situation. And so in this HHS report, it talks about all of the different, avenues that are being taken across the department, and importantly, they are very much aligned towards this whole person care that primary care really, stands for. So for example, the Health Resources and Services Administration, HRSA, they're supporting the National Health Service Corps, training grants for residency programs and, for other workforce. You have SAMHSA that has training grants for better integration of behavioral health with primary care and providing, an evidence basis that people can use to be able to better integrate. You have ARC that's putting together, an evidence base for primary care. And all of that is important and dovetails with the work that we do in CMS, right? Our main lever is on, the payment side for providers, and hopefully you all have seen the work that we are doing to really further primary care, because we do see that longitudinal care as being critical to really address the needs of people, which gets to issues of disparities in advancing health equity. It gets to prevention and keeping people healthy so they're living in their communities rather than spending time in the ER or the hospital. So some of the things that we have done recently in the latest physician fee schedule, we finalized this add-on code G2211 for primary care. Yeah, so and I don't think I have to explain to all of you the value that comes with taking that extra time to really get to know someone and to gain their trust and to be able to have conversations with them, because you know that whole, the doorknob conversation. It's like, as a physician, as you're leaving the office and you have your hand on the doorknob, that's when someone says, actually, there's one more thing, can I talk to you about, right? And so, having that is very important to really value the longitudinal aspect and the complexity of people that primary care takes care of. And we also finalized payments for community health integration, for where addressing social needs are part of a care plan. That also very much dovetails with the work that primary care does. Care navigation for serious illness. In fact, the First Lady, did a press call on it, because care navigation is really personal for her, both, through her sister and her son. And also payments for caregiver training, because we also know, especially in a Medicare population, that unpaid caregivers often are the crux of health for people who rely on the Medicare program. And how can we support the healthcare providers who are supporting the caregiver? So I think those are just some examples of where we really are trying to support primary care. And to the point you made to start, the job is not over. This is just the beginning, and it's so important for us to be able to hear from all of you of where there are opportunities to inform our policy making, but also now when we do roll out policies, to make sure that they come to life on the ground in the way that all of us are envisioning, to really further our goals around advancing health equity, driving whole person care, being able to expand access to care, and enabling us to be good stewards of the program, so that ultimately the dollars that we are spending are being spent in the smartest way to provide better care and keep people healthy.
Well, thank you very much for all of that fine work, and we certainly appreciate these important modifications to the fee schedule and add-on codes and all of that. At the same time, we're going to keep fighting for and working in partnership with you all to really move towards new payment models.
Yes.
And more investment in primary care, and we want those to go on simultaneously. We have some important work to do right now to affect primary care's ability to provide more comprehensive care. I think some of the things you mentioned really can help do that. And yet we know we need very different models, and we need a much higher level of investment. And frankly, we need to look at the fee schedule and what it's valuing. But before we get there, we started off our day on Capitol Hill with the voice of the patient, a short video clip, and then a longer presentation by a patient. And it really, I think, inspires us and motivates this entire community. What's different, and how are you getting patient voice and patient views on how our system should be constructed at CMS?
Well, I will say that, and this comes from my taking care of patients up until I took this role. Ultimately, everything we do is for those, more than 64 million people who rely on our program. And so it is incredibly important that we hear from them. And just to give one of the most recent examples of how we incorporate that voice, we just held 10 patient-focused listening sessions on each of the 10 drugs that have been selected for negotiation in the Medicare program, so that we could hear directly from people about the benefits of these drugs, the challenges with taking these drugs, so that we can gather that information. And I think we have regular meetings with patient groups. Our door is always open because we want to hear from everyone as we are developing policies. And again, it's great to put something in a 2,000-page regulation, but it's important that people understand what is available and that they know how to navigate, how they can make the best option, the best choices for them. We're in Medicare open enrollment right now, so I'd be remiss not to mention it's Medicare open enrollment right now. So until December 7th, and it's so important for people to be able to navigate their options. So for example, we heard loud and clear that the marketing of Medicare Advantage plans is oftentimes very confusing and misleading. So we put in place additional oversight and regulations around marketing. And in fact, we rejected more than 300 television ads this open enrollment cycle that we found to be misleading. So, really, this is all coming from feedback of people on the ground. And I think it's also important for us to, especially as we're talking about transforming care, if you walk down the street and say, hey, what do you think about value-based care? You know what looks you're going to get, right? I mean, but I think we all know that this is what people feel they're missing in their healthcare. Like, they want to be felt like they're treated like they're a person and not just an ICD-10 code. And so how do we convey that to people as well, so that way they can engage in their care and they can be part, of the journey as well with us?
A quote that we heard this morning is, we don't need more paperwork, we need people. This was from a patient, and primary care is where the people are. So we could not agree more. And I think that how do we get administrative simplicity? How do we get back to relationship-based care? How do we not have primary care practices spending gobs of money on administrative folks doing the billing and all of the coding and all of the quality reporting? Hopefully AI will help us with that. But I think you're right. We want to get back to being able to truly provide relationship-based care, and new payment models can help us do that.
I think new payment models can help, and I know we're probably going to talk more about that. And also things that we're doing, for example, with our national quality strategy to align the quality metrics across our programs, because I too was leading care transformation at a major health system and had that huge spreadsheet with 8-point font trying to keep track of all of the quality measures of all the different programs, right? So, Doug, who is here, we co-authored a piece in the New England Journal of Medicine on, our universal foundation, coming up with a core set of quality metrics across our programs and really trying to align, again, towards that point of how do we make things streamlined so that people can focus where they need to. And another example I'll give is prior authorization. We did a request for information on the Medicare Advantage program, and we got more than 4,000 comments for that request for information. Every single group talked about prior authorization. And so we streamlined prior authorization in Medicare Advantage because that is a major source of workforce burden and barriers to access to necessary care for patients. And so that also is where, we really are thinking about ways that we can make sure that people are able to do what they went into healthcare to do.
Thank you. We have been working with a partner organization, the National Association of ACOs, and 27 other organizations that are diverse, including patient groups, health plans, and the like, to advance an idea to CMS for a hybrid payment in MSSP. And we're excited to be having these conversations, and in fact, we convened a group of consumer organizations to provide input. What do you think the primary care community can do to advance additional models and to move these ideas even more rapidly? The platform, COVID was a sucker punch. It is not strong. It takes a long time to get models up and running. Meanwhile, independent practices are going the way of the dinosaur. Folks are retiring early. I mean, how can we move this whole apparatus more rapidly? What can we do as a community to partner with you and provide many more options for primary care to participate in these models?
Yeah, I mean, I'm really glad that we're talking about this because I think it goes without saying that the holistic approach that primary care takes to caring for people is ultimately what we're trying to get everybody to do. And, we really are looking at aligning across our programs so that we can get 100% of traditional Medicare beneficiaries in an accountable care relationship by 2030. And that means starting from fee for service, going all the way up to the innovation center models, that we are, creating this pathway across the program. So what does this mean? Aligning the quality metrics across the program so that, when you are participating in MIPS and you're in fee for service, Providers are starting to have, the same accountability that then would be in the Medicare Shared Savings Program. And then the Innovation Center can test, the next generation of quality metrics. Where we are finalizing payments, like I mentioned, around community health, care navigation, so that providers can develop the muscle memory needed in population health to then move into these payment models. The goal is not, okay, now you can stay in fee-for-service. The goal is, now you can get some additional, because I've heard traveling the country that there are cash flow issues, right? Where you want to invest in infrastructure and these team-based approaches to care, but it's hard to do that if you have to wait 2 years before you get a shared savings payment. So being able to provide some of this up front, the idea is so then you move into MSSP or another model. And I think we could really use all of your help in making sure that that is happening, providing support for providers who are like, I don't know if I can do this. No, you can. There are best practices. There are those who can help. And I think another thing that's important is we really want to use the Medicare Shared Savings Program as a chassis for testing, new ways of care. And so being able to provide concrete suggestions about here's something that you could test, I think is very important as we are partnering very closely with the Innovation Center to be able to take what they test into the Medicare Shared Savings Program and the physician fee schedule. So those are just some concrete examples.
Great, thank you. So you mentioned traveling the country. I am sure you are privy to lots of great innovation that's going on. We heard many of this at our conference today. And what are you finding that is really inspiring?
Yeah, I will say I also travel the country as a double travel sports mom, which I never anticipated becoming. But, I think, oh my gosh, what example to provide. I recently went to New Orleans and I met with Oxnard Health System, Xavier University, historically black university, and Delgado Community College. And they are partnering together on workforce development programs in the local New Orleans area. For example, shadowing programs for high schoolers to see what it's like to work in healthcare. Training programs for peer recovery coaches, for community health workers. I also went to Florida, met with the Florida Behavioral Health Association, who were over the moon that we were, at that point it was still proposed, but that we were talking about paying for care navigation that peer recovery coaches could do. Because they're like, we can train people, but the question is, how do they get employed? There needs to be that, revenue stream, business model for them to get employed. And so I really think those unique partnerships with the community, that's a win-win on so many fronts, right? Because you are hiring people from the very communities that are underserved, and they're going to do a much better job caring for their local community than other people would. And it lifts the economic status of people in that community. It gives them jobs. And again, with the Florida Behavioral Health Association, one of the rehab facilities was talking about how when they have people coming into rehab and they're talking about job prospects, employment prospects upon graduating from the rehab program, they're like, we want all of them to get employed as peer supports, right? And so they were super excited about what we're doing to be able to pay for peer recovery, because then that creates a whole pathway to dramatically change someone's life, where coming out of this, they can bring that expertise to then change the lives of others, and for them also to then have that economic independence and that sense of I can make a difference, and give them meaning in their life when a lot of them had lost meaning in their lives. So I think those are just two examples on recent trips that I've done.
Well, it's a great example of a virtuous cycle.
Yeah, absolutely.
Right? And one is reinforcing the other.
Yeah.
Really positive. We care a lot about not just improving physical health in the primary care space, but also mental health and integration of behavioral health. And historically, Medicare's not been the best payer, and you're not the only payer that has not been the best payer. Treating the brain as if it's sort of outside of the body. So you mentioned a couple of things in the fee schedule, but what else are you doing and what are you contemplating? You probably, maybe you can't say, but you know, what are you doing and what challenges remain that you know you really need to work on?
Well, we have made some of the most significant changes in behavioral health in the Medicare program in decades. I would say since the start of Part D, which enabled more pharmacotherapy, which is very important for behavioral health as well. So for example, thanks to congressional action, we have finalized a new benefit in the Medicare program, an intensive outpatient program, where previously someone could have an acute inpatient psychiatric hospitalization or do a partial hospitalization program, and there was nothing except for outpatient therapy and like outpatient psychiatry. Now there is an intensive outpatient program that fills that really critical gap. We've also expanded the providers who can enroll in the Medicare program and see Medicare patients and bill. Licensed marriage and family therapists, licensed mental health counselors, including addiction counselors. I mean, it's roughly 400,000 clinicians in the country who were previously unable to enroll in the Medicare program now could enroll in the Medicare program, which is huge for access to care, especially in underserved areas where you may not have access to a psychiatrist, right? We already finalized making telehealth permanent for behavioral health, including audio only, which is important in rural communities that may not have broadband. And, we also already finalized paying for, if a psychologist or social worker provides behavioral health during a primary care visit, there is a payment for that, right? It's taking that collaborative care model to scale. So those are just some examples of really the tremendous changes that we have made fundamentally in the Medicare program to acknowledge the importance of behavioral health, to bring care to where people are, and to really integrate more in that team-based approach that's needed.
Super. And what are the challenges still to move this forward? Because, I think the mental health challenges, both for adults and for children, loom large.
Yeah, just immediately, as I said before, it's great that we put all of this in a, several thousand-page regulation. We need to get these providers enrolled in Medicare. We need to enable people to understand best practices of how you can integrate behavioral health and primary care and physical health. And similarly, as we're looking at community health supports and care navigation, how do people do those things, right? Like there's a lot of best practices that can be shared. How people can utilize money to contract with the community-based organizations. So I think there is a lot of work that remains to be done to take the policies that we've finalized and really bring them to life. And I would say that there continues to be, it's getting better, but there continues to be significant access issues, significant stigma around accessing behavioral health that I think all of us can really play a role in just continuing the conversation. I was doing an event on caregiving. Let's talk about the burnout of unpaid caregivers, right? And family caregivers. And this is where I think the worlds collide, right? Between the aging of our population, the mental health crises that we have, and it's so important that there are conversations happening now about this, where people should be able to get support and say, I need support and be able to access that. So I think there's a lot that is still ahead for us.
Well, we're so pleased that you're in the position you're in and are really helping to lead so many of these changes. And so please join me in thanking you for all of your work.